Good afternoon. Thank you for joining Decoding Disparities, Community Conversations to Decode Health Inequities, presented by Brown University's Warren Alpert Medical School and School of Public Health. This lecture series is designed for all faculty, students, staff, and alumni, and is certified to offer AMA PRA Category 1 credits. The Warren Alpert Medical School is accredited by the ACCME to provide continuing medical education for physicians. The speakers and planners for today's lecture have no financial relationships to disclose. On this slide, you will find the privacy, disclosure, and disclaimer policies of the Brown Office of CME. Thank you for your attention, and it is my pleasure to turn it over to the formal introduction for today's guest speaker.
Good afternoon. My name is David Williams. I'm an associate professor of behavioral and social sciences and psychiatry and human behavior at Brown University. I'm also the director for the Center for Health Promotion and Health Equity located at Brown University's School of Public Health. Alongside Ashish Jha, Dean of the Brown University School of Public Health, and Jack Elias, Dean of Biology and Medicine and Senior Vice President for Health Affairs, both of whom could not be here today, I'd like to welcome you to the Paul Levenger Decoding Disparities seminar series. This seminar series is part of a joint effort between the School of Public Health and the Warren Alpert Medical School to focus on the inequalities and health disparities that exist in healthcare today. Although health disparities are certainly not a new issue, we are now at a moment in history where unprecedented public health crises and mass movements have collided to shed light on centuries of systemic racism in the United States, including within the healthcare industry. As academic healthcare leaders, we have a responsibility to build community awareness and create a safe space for current and future healthcare professionals to discuss economic and racial discrimination and inequity. This lecture series is part of that effort. Our goal for you after this lecture is that you will have a better understanding of where we need to make progress and what still needs to be learned as we work to close the gap on racial, economic, and social disparities of healthcare in America. Before I go further, I'd like to thank those who made this series a reality. I'd like to thank my colleague, Sharon Rounds, Associate Dean for Clinical Affairs at the Medical School, who worked alongside me to create this robust series. I'd also like to thank our superstar teams from both the School of Public Health and the Warren Alpert Medical School that have worked tirelessly to bring together a superb lineup of scientific leaders on this topic. And I'd also like to thank the members of both of those teams who continue to work behind the scenes to make this all possible. We're also lucky enough to have this lecture series supported by the Paul Levenger Professorship Pro Tem in Economics of Healthcare, which is funded through an endowment established in 1987 to honor the memory of Paul Levenger. The gift was made by his wife, the late Ruth Levenger, their daughter, Betty Levenger Cohen, and her husband, Dr. John Cohen, a pediatrician, Brown class of 1959. We are pleased that Betty and John have been regular attendees at other Levenger lectures over the years and will be joining us again throughout this series. It's support like that of the Cohens that allow us to continue to do this important work. Now I would like to invite Dr. Jake Curtis to introduce today's very special speaker, Dr. Albert Coe, whose research centers on problems that have emerged of a consequence of rapid urbanization and social inequity. Thank you. Jake?
Thanks so much, David. It is my sincere pleasure to introduce to you a true rock star in the global health research community and my good friend, Dr. Albert Coe. So Albert has always had a remarkable ability to just do tremendous work, and it begins in his early training. He got his undergraduate degree at MIT, his MD at Harvard, his internal medicine residency he did at the Brigham, infectious disease at Mass General. Really, it's just a tremendous pedigree. He spent 3 decades working on health disparities in rapidly urbanizing populations, with a specific focus on infectious diseases. He's currently the professor and chair of the Department of Epidemiology of Microbial Disease at Yale, and interestingly, a collaborating researcher at Oswaldo Cruz Foundation for the Brazilian Ministry of Health. The reason I want to highlight that is what Albert has done is very unique in the global health community. He spent the better part of the midsection of his career, 15 years, living in country amongst the communities that he was engaged in research and clinical care for. It's a very different model, and I think you'll see in his lecture that having that deep integration with the individuals he's seeking to both study and help has a profound impact on his understanding of their sort of contextualized experience of infectious diseases in the context of urbanization. Currently, he's been NIH funded for decades, been working on 3 diseases primarily: Zika, Leptospirosis, Schisto, and dengue, sorry, 4. And we're really excited to have him. And so with that, Albert, please tell us what you've been up to.
Yeah, thank you very much, Jake, for that kind introduction. And it's truly an honor to be able to give this talk to Brown University, both the schools of medicine and schools of public health, and also about this subject, which is, I think, close to the hearts of many of the people in the audience and myself. And that's specifically on the issue of urbanization and its impact on health disparities. And today I'll call on, as Jake had mentioned, really the experiences of our group and our team at the Brazilian Ministry of Health, specifically the Oswaldo Cruz Foundation, which is situated in the city of Salvador, Brazil, which is the 3rd largest city in the country, as well as our large team at the Yale School of Public Health. And with that, I'm going to focus on three sets of issues. The first is an overview about how urbanization and social inequity serves as drivers for health disparity. And I'll be taking a more global perspective on this, maybe a divergence from the other lectures in the series. And specifically, I will draw on really the lessons learned and experiences that we've had in dealing with pandemic, epidemic diseases, as well as endemic diseases in Brazil. And this is particularly in the city of Salvador, in the northeast of Brazil. It's a city of 3 million people. And really highlighting some of the issues of really the interplay between different drivers. And these are poor environments, social gradients, and also the challenge when we're thinking about urbanization and social inequity and how that impacts health disparities. The issue of heterogeneity and scale, which are key in both the challenges, but also in the solutions. And then taking that into what may be lessons learned and opportunities for intervention and change in the urban setting as the world is dramatically being transformed. So with that, let me also say the other disclosure on this is that as Jake said, I'm an infectious disease physician. Much of the work that we've been doing, in Brazil has been focused on the emerging infectious diseases in these urban slum landscapes. And so much of my talk will be focused on infectious disease examples and kind of biased towards that, but I will touch base on really the other large challenges that we face in mental health, environmental health, as well as non-communicable diseases. But with that, I'd like to start off with this slide, which really tells us, an issue where we came from. And this really captures what we've experienced over at least my lifetime. Since the 1960s. And we've seen dramatic improvements in health quality and across the board, whether from high income countries or the least developed countries. We can see this with respect to life expectancy and the increases, decades of increases that have occurred in the last 60, 70 years. And we can also see the dramatic decrease in childhood mortality. But this slide also captures what the challenges for the present and the future is really the inequities, at least in these large regional and economic levels between the least developed and the highest developed countries and populations in the world. And I would make the assertion, and it's partially correct, but that much of these improvements in really the health status is really been driven by much of what has been done by infectious diseases, whether we think about immunizations, vaccines, oral rehydration, but also addressing social determinants of health and their impacts on health outcomes. Yet that hasn't addressed entirely the issues of disparities and inequities that are inherent in this process. And then when we're thinking about this, and again, through the lens of somebody who's an infectious disease epidemiologist and physician, and I'd like to call upon this model, and these drivers, which were highlighted by, I think, two very prescient documents. They were both commissioned by the Institutes of Medicine. They are both focused on emerging infections and microbial threats. But when we think about these have played out, and unfortunately played out eloquently as we're experiencing now with the COVID pandemic. But I think the most important part is really the paradigms. When I was a medical student and being trained, our focus was pretty much the microbe in the humans, and that's as a traditional infectious disease physician or as well as epidemiologist. But we really know that the paradigms, whether we're learning and training, or the paradigms, whether we're identifying interventions or implementing those interventions, require a much larger model, such as the convergence model proposed by the Institute of Medicine. And I think several parts, I'll come back to that model, because it really captures what we're doing now and what we need to do in the future. And I think we can think, and in this series really captures many of the interactions. The central theme, of course, is that of disparities, which is the health disparities, which is the outcome. But in thinking about processes and drivers, what are the things that are changing us, have changed us in the past, are changing us today, and will change us in the future? And that's really the demographics, the tremendous changes in age distributions around the world. The second, of course, is climate change, which was highlighted in a prior lecture in this series. The other driver, which is central to the issue of disparities, is the role of poverty and social inequity. And of course, many of these are imbued into issues of globalization, which we've occurred on. And for today, I'd like to drill down on specifically the process of urbanization and how that has shaped what health is for us now and how it will shape us in the future. And just to go back, I think the first time in human history, around 2007, we had more people living in urban centers than we have in rural regions in the world. And that population, by 2037, the majority of the world's population will live in urban centers in the poorest, most vulnerable regions of our world globally. And you can see on the right-hand side how large that urban population is. And the drivers for that, how the drivers of that process of urbanization spill over when we think about processes of how urbanization impacts on health. And just to give you some vignettes and how these interactions play together, and thinking about a more holistic rather than a fragmented type of understanding of processes, I think surely the one that we're worried about in all of our cities, including the United States, and the most developed as well as the least developed, is the process of the change in human demographics, the increasingly aging population, many of them residing in healthy cities, and the large projected epidemic of non-communicable diseases, whether it's hypertension, asthma, diabetes, metabolic syndrome, and so forth. Thinking more on the, how of examples of infectious disease illustrate those processes, I'll go through several, and some of them draw off the experience in Brazil, but I think one that really is kind of a fascinating example is how rural to urban migration drives increases in disease burden. A good example is a disease that we thought we've kind of gotten rid of, which is in Brazil, it's called Hanseníasis, but it's leprosy, and how we had migration of rural poor with poor environmental conditions, with high transmission of leprosy, moving to urban centers, peri-urban slums, and pseudo-epidemics that have occurred. Brazil, for example, has the third highest burden in terms of cases of leprosy. It's a disease that hasn't disappeared. India is another good example of such phenomenons. The other is the issue of changing ecosystems. So as we're changing the urban landscape with rapid urbanization, we're seeing what are called underlying drivers and processes come out of that picture. I think one of the best examples is the example of arboviral infections. I'll talk more about Zika, but to mention about dengue. So dengue was a disease that was eradicated or eliminated from the Americas back in the 1940s and 1950s through vector control, community-based vector control, done by heroes like Soper, Fred Soper. And that was done to not only eradicate dengue, but to eradicate yellow fever or eliminate yellow fever from the Americas, which never happened because of a zoonotic cycle. However, because of urbanization, it brings me back to the movie that was formative in my lifetime, which was The Graduate. Plastics, the use of plastics, the lack of access to refuse collection, urbanization. We've had massive outbreaks, where we've had outbreaks or epidemics in cities that have served as the nidus for spread throughout regions and countries. And so dengue came back with a vengeance, starting in the 1970s through the 1990s throughout the Americas. Another good example of how these drivers inherent in the process of urbanization can fuel disease, adverse outcomes and disparities is the issue of overcrowding in movement. We've seen that in many different forms with SARS, MERS, Ebola, and now the latest example of COVID. But I think one example that captures that intimate relationship with social inequity is that of tuberculosis, and particularly in South Africa, where you have people living due to apartheid and socioeconomic factors in peri-urban settlements or slums or shanty towns, townships, and migrate every day, have to go into the city, on minivans, on mass transport, where the risk of tuberculosis is essentially fueling the transmission of tuberculosis in these settings. And then another example of another process is that as people moved from rural environments or rural settings where they had no access or limited access to healthcare, they're moving to urban centers where they have increased yet inadequate access. And that's been one of the primary drivers of antimicrobial resistance. We've seen that play out in places like China, where there's been large, dramatic shifts in populations from rural moving to urban, access to healthcare, yet inadequate access or inappropriate access to healthcare. And we've seen this, been associated with large multi-drug resistant tuberculosis burdens in that country. And we can see how all of these processes interact or synergistic together. And I think that really one of the brightest examples, or unfortunately the brightest example of that, is how that plays out for the most vulnerable of our populations that live in urban centers throughout the world. And those are the inhabitants of urban slums. It wasn't until the early 2000s, 2003, that we actually had a unified, definition or a clear case definition of an urban slum, as well as populations that live that. That's based on inadequate access to safe water and sanitation, poor housing, overcrowding, insecure land tenure. And at that time, back in around, in the 2003, there were estimated 1 billion, inhabitants of urban slums, which makes up about 78% of the urban population in the least developed countries. And that, driven by issues of social inequity, but also by rapid urbanization in the lower middle income countries, that population is going to double by 2 billion. And I think one thing that really kind of captures that phrase, and I like this quote from Pankaj Mishra, who presented this in one of his book reviews in the New York Review of Books, is that migrants from impoverished hinterlands living without security, public health, and often clean water, the shanty towns of Sao Paulo, Lagos, Karachi, Dhaka, and Jakarta have much in common with each other as people like us, the global class of businessmen, journalists, academics, and anti-terrorism experts do among ourselves. So we've had a realignment of populations across borders, across settings, across regions. And let's look into that a little bit and how that's played out. And I go back to the example of Brazil. Brazil is a country that I think is a paradigm, serves as a paradigm for increasing social inequity and rapid urbanization, almost as a laboratory. It urbanized fairly quickly in the 60s and 70s, very rapidly across, three decades. Now, 88% of the Brazilian population lives in cities, compared to the early 1960s, where half of them lived in rural regions, half of them lived in urban settings. Diseases such as Jake and myself work on, schistosomiasis, leishmaniasis, Chagas disease, the great endemic diseases, have really disappeared, partially because of this rural to urban migration and demographic shift. However, and Brazil is also a country, like many of the lower middle countries have witnessed or will it witnesses, has been a country that has grown tremendously. You can see in this graph on the x-axis the increase of in gross domestic product that's occurred over the span of 20, 30 years. So large increase in large economic growth. However, you can see on the y-axis is the Gini index. And you can see there have been ups and downs in that Gini index, that index of economic inequity or social economic inequity. You can see that it's still high in Brazil. Now in this decade, is still one of the highest countries with respect to social inequity. And you can see this if anyone has flown into the city that I've worked in, Salvador, São Paulo, Rio de Janeiro, or whether it's Lagos or Mexico City, you can see what's called in Portuguese ilhas de desigualdades, these islands of inequities, where you can see built up middle class, upper middle class communities juxtaposed with these these disorganized urban slum settlements, often called favelas in Brazil. And you can see how that interaction really disobeys geometric distance. You can see how many times you can have the have and the have-nots very close to each other, thus leading to this issue of externalities. Violence is a good example. Infectious disease is another. But you can also see that given, although these are very close in geometric proximity, the social distances between these communities are exceedingly wide and spread apart. Probably the social distance between this community here on the right-hand side and Orlando and Disney World is much shorter or much than it is with the community right next to it. And in that setting, that was, as Jake has mentioned, we've been working for the last 3 decades or last 25 years in Brazil to address the types of problems in the training, particularly the training needed and the capacity building needed to address these emerging slum health problems in those communities, in the vulnerable communities in Brazil. And this was a program that was established by the Oswaldo Cruz Foundation, which is the National Institutes of Health equivalent in Brazil back in mid-1996. Very much focused on training and capacity building. We had to realign people who were trained for the great endemic rural-based diseases to work on these urban diseases. So it supported large investments through the Ministry of Health, Brazilian Ministry of Health, in partnership with local and national public health institutions. And I think one of the guiding principles for this program was community as equal partners in research in health. And I'll say why that was important, but the major issue was that the heroes, the actors, the players in this whole story has to be the community, and the community in determining and identifying solutions for their own health problems. And we've used these models to build capacity to address health threats across the board. We have groups working, part of the groups working on non-communicable diseases, violence, food insecurity. The majority have been worked on a slew of infectious disease problems. When I first went to Brazil, meningococcal meningitis, we had large epidemics throughout the country, throughout the urban centers. Horrible epidemics that occurred, and these were vaccine preventable diseases. The arboviral diseases, dengue, chikungunya, Zika, another good model of urbanization, social inequity, and I'll come back to that. And the one that I'd like to kind of start with is the one that we started off with, which is Rat-Borne Leptospirosis, which is really serves as a paradigm to understand how these underlying processes of urbanization, social inequity are synergistic in producing unequal, health outcomes and health disparities, but also how we can address them, and what are the low-hanging fruits in terms of interventions. So as I mentioned, we've had concomitant changes in demographics with rural to urban migration and urban population growth. We've had increasing socioeconomic socio inequity in Brazil and much of the lower middle income countries. But I think the other change that has happened is really the change in the urban ecology and the urban landscape. This community, where we've been doing long-term cohort studies of 3,000 people since the early 2000s, this community of Pau de Lima, captures kind of the history of many Brazilians. About 35% of Brazilians live in communities such as this. This was pristine Atlantic rainforest 40 years ago. And because of squatting and urban rural migration, and squatting is now a densely populated urban community, 28,000 people in 1 square kilometer. You can see half of these people live at the poverty level, which is less than 2.5 per capita household income, less than $2.5 per day. There's open sewers. There's lack of services in this community, basic services, open sewers, accumulated trash. And when we think about the ecology, the most successful species in this environment has not been humans. It's actually been, it has been human adapted species, and that's rats. So you can see on the right-hand side, this is an earthen stairwell where people go back up and down, this community. And you can see this is all these holes here. These are rat burrows. So high density of rat populations living close to where people live. And this plays out. There's, as a plague of rats. This is just a science article that was written, Science magazine article written about the work that we've been doing in Salvador. But that plays out in terms of new diseases and emerging diseases with the shifting demographics, shifting ecology, and shifting, processes of social inequity. And that's captured by this epidemic curve. So this is leptospirosis. These are cases of leptospirosis. Leptospirosis is a zoonotic disease caused by a bacteria. That bacteria is harbored by the reservoir are rats. It's excreted into the environment in soil and water where it can survive for weeks. Humans come in contact, if there are cuts either through the mucosal membranes or cuts in the skin or abrasions, the spirochete can penetrate and disseminate quickly, and it causes life-threatening disease, such as Wales disease, which is the triad of acute renal failure, jaundice, and bleeding manifestations, and also severe pulmonary hemorrhage syndrome, which was a major cause of death in these urban slum communities. And you can see the other factor here. This is actually, if you look at the epidemic curve, you can see there are very predictable epidemics. And this, if you can take this epidemic curve and you'll see the same one. This is the city of Salvador. You'll see the same one in Rio de Janeiro and Sao Paulo. You'll see this also in Jakarta. You'll see this in Manila, Guayaquil, Cali, Colombia, where you have, every rain season or season or a period of heavy seasonal rainfall, you have these very predictable how to say it, predictable epidemics that occur. And these same kind of, so this new epidemiological pattern or these rainfall associated epidemics, they attack the same slum communities each year. Transmission is rat-borne. These same conditions that we saw, and this is work all done in Salvador, but has actually served as a model in Brazil about how to understand and also how to address these urban epidemics, are found throughout the developing world. In Brazil alone, we have 12,000 cases of leptospirosis each year. Our intensive care units are filled with people receiving dialysis or mechanical ventilation because of the pulmonary hemorrhage syndrome. Case fatality rates are over 10%, approaching that over 50% for the pulmonary hemorrhage syndrome, which is equals that of what you observe with yellow fever or Ebola. And just to give you an idea about this issue of how place matters, how where you live at different scales influences your health outcomes and disparities in health outcomes. This is a satellite map of the city that we live in, the city of 3 million people. Just by remotely sensing whether somebody lives under a steel corrugated roof versus a tiled roof, we can actually use that combined with census data. And Brazil has, one of the best census data in the world to come up with a land cover classification. Also using canonical correlation analyses, really come up with a map of vulnerability, where these slum communities are at a very granular level that can be used not only for targeting interventions and focusing to address the most vulnerable, but also to think about how to do disease control. And these maps are almost superimposable. The maps of leptospirosis cases, which are GIS mapped, with that of the vulnerable communities, these urban slum communities in the city. Understanding, at least in the scale of not only countries and regions, but the country within cities, that variation. And to really understand that further, and I'll draw on some of our long-term cohort studies, ones that we've done in 2000, particularly in one of these hotspots, in one of these prototypical peri-urban urban communities, that of Pau de Lima, which I mentioned before, and just thinking about how these different factors interface with each other. We've talked about the importance of climate and rainfall, and this becomes ever more critical when we think about climate change, and not only increases or averaged increases, but also increases in extreme events that drive transmission of a disease like leptospirosis, as well as many others. But also the issue of social gradient, accounting for other, controlling for poor environment, factor of poor environment. We can see that there's still within a poor community, or overwhelmingly poor community, small differences in per capita household income make large differences in health outcomes. And at least for infectious diseases, we've done this for leptospirosis, dengue, toxoplasmosis. You'll see that for like every $1 increase in per capita household income, you'll have a 20 or 30% decrease in the risk of infection. And that also plays out with this interaction, this very intimate action in many slum communities between geography and socioeconomic status. You can see in this panel A here, you can see the slum community, the poorest of the poor, the recent migrants from the rural regions live in the bottom, where they have less access to sanitation. They have and services. They have they get flooded. The land quality is poorest. You can see every time it rains, people have to go into the open sewers to create a barrier. So then the next time it rains, it doesn't flood their households. You can see this resident here pointing out where the flooding is. So this issue of vulnerability is not only at the country or the regional or the city level, but at the micro level of the environment. And that poses a challenge when we're thinking about interventions in public health and how do we address those issues of inequity. So, but the overall theme here is really this synergism between geography, climate, and social gradient that plays out. And I think I like, I trained in Boston, and one of my favorite politicians at that time of the training was Tip O'Neill. And I think what he said for politics, that all politics is local, really goes for public health. We can think globally, but our actions are local. And when we're thinking about, urban slums, when we're thinking about disparities, health disparities in urban environments, that's driven by local actions and local actors and players. And just to give you an example of how this was addressed, in the city of Salvador, but that model was actually exported to all of the, by the Brazilian Ministry of Health as a priority to all the major cities where epidemics of leptospirosis came. It's just really grounded on those principles that there are defined structural determinants, environmental, both environmental and social, that many of these are open sewers or really lack of access to sewerage and rainwater drainage, and how that, that an answer to this have to touch on several pressure points, whether it's not only the poor environment, but also the issues of social gradient, and how that formulated, this is back in the 2000s, that this policy that, we informed and worked with the Brazilian Ministry of Health, informed multi-level interventions based on health or education, targeted rodent control, forecasting, and using that. And I think this is really where the biomedical part came in, is that, we immediately had a lab team dedicated to get rapid diagnostics so that we could identify cases of leptospirosis early in the illness, get them treated by antibiotics, and prevent the severe outcomes such as Wales disease, acute renal failure, and pulmonary hemorrhage. But I think probably the most important part of this story was really what the community did. So using information provided by the Brazilian Ministry of Health, the community leaders, actually probably mobilized the most important intervention that took place. And that was really here in the periphery. Salvador actually, through a very vertical program, had received $1 billion to improve its sanitation system. But that improvement in the sanitation system was driven by tourism, by cleaning the beaches so that they could get economic growth through tourism, and neglected the peri-urban slums. And the community leaders in these, using this data, working together through a community participation model, convinced the Ministry of Cities in Brazil to invest in extending the sewage networks to those places that had not only the highest rates of leptospirosis, but the highest rates of toxoplasmosis, diarrheal disease, and so forth. And this led to over a 4 or 5-fold decrease in the incidence of leptospirosis over about a 10-15 year period. So let me just switch gears to just touch base quickly on another example of, in Brazil, homegrown example in Brazil, of really these kind of the coalescence of different drivers and how that played out. So this is obviously the perfect storm of what happened with the Zika pandemic in the Americas. Because of the decline in vector control, urbanization, many different habitats created by the lack of refuse collection, particularly in the most marginalized and poorest communities and cities. With the point source introduction of Zika, and that likely happened in the city that we were working in. We were at the epicenter of the Zika epidemic. This blew up into a large pandemic that everyone knows the story that happened in Zika. And this is really fueled by the, you have a uniformly susceptible population together with a wildly out of control expansion of the vector for both dengue, Zika, and chikungunya. And many of you know this played out. We were at the epicenter of the microcephaly epidemic. And I think one of the key issues that we found, this is where we had cohort studies going on, really the high attack rates that occurred in these urban slum communities. We had within a 3-week period, 3-month period, 4-month period, attack rates of Zika that went above 70% in these communities. And going back to the issue of this disparities, the Zika epidemic was an epidemic of primarily the poor, marginalized communities, not only in Salvador, not only in Brazil, but throughout throughout the countries. This is just the experience of one of the private hospitals, births that occurred during the microcephaly epidemic versus that of one of the public hospitals. And you can see where rates of microcephaly were tenfold higher among those in the hospital that served slum communities versus that served the upper and middle class communities, and where attack rates or actually seroprevalence among women giving birth were 3 to 4 times higher. Just giving another example of how, in a different, mosquito-borne disease, infectious disease, how these issues of disparity, of inequities and urbanization play out. And, this actually led to, really, and this is really a good example of the importance of good governance, how you're going to shape vertical programs to address issues of inequities in a community-based format. This is one example of, many of you have heard probably of the Wolbachia infected Aedes aegypti. These are mosquitoes that you infect with a bacteria, Wolbachia. Transmission within these mosquitoes of dengue, Zika, and chikungunya is decreased. There's been a large randomized controlled trial done in Indonesia. We are doing them now in urban slum communities in the city of Belo Horizonte, a large cluster randomized study. We've just started recruiting. Well, actually, we're almost in the middle of recruiting 3,480 school children, and we'll close recruitment in December, start the intervention as a method, as a vertical intervention that will be employed in a community-based level. And so on that, I'm going to switch to the last part of the talk, was really gets at, so how do we move on from there? What were the lessons learned, and how do we go on? And I just want to throw out first that the story I've told is looking at the dark side of urbanization and in social inequity. But there is a positive side. There is a reason why people from poor, marginalized communities in the rural areas, rural regions, move to urban slums. And that's really captured by these graphs here. You can see that overall, urban, there's less urban, there's improved outcomes with respect to infant mortality and child mortality in rural communities versus urban communities versus rural communities. However, the inequity or the distance of the difference between the ratio between the poorest and richest are accentuated by urbanization. So urbanization overall, as an average, produces better health outcomes because of access to health, access to education, housing, sanitation, so forth. But these benefits of urbanization are proportioned disproportionately across different segments of the population. And to give you some vignettes or some examples of what kind of we learned in Brazil and how that would help beyond Brazil, but also to the United States. And I think there are several points to hit on about when we're thinking about the future, what worked and what didn't work in Brazil. There are quite a number of things that didn't work, but what worked is, one is the strong constitutional legal framework for social rights, which makes provisions for medical care and access to public health, including immunizations, and has a structural basis for social rights with respect to the social determinants of health, whether it's water, sanitation, education, housing, land tenure. Implementation is certainly an issue, but there is a structural basis for that in the Constitution. The Brazilian Constitution is like 90 pages, whereas the US Constitution, which doesn't guarantee social rights, is much less. I think the other part from Brazil is, without the universal health care, many of these vertical programs, whether it's HIV, universal access to HIV medications, or whether it's immunizations, or whether it's the rapid test that we developed for leptospirosis, would not have happened without the strong universal health care, which provides access to public health as well as medical care, and that integration of public health with medical care, which is key to the Brazilian SUS, or Sistema Único de Saúde, or the universal healthcare system. The other thing that's inherent, which is there's a constitutional framework, is community participation. every health post, every national immunization program, whether it's city, state, or national, is mandated to have community participation. 50% of the members are from the community. And that diversity in the perspective of the community has been key to many of the successes. I think one of the major successes or shining lights of Brazil has been their immunization programs. Programs such as community health workers. We don't have a robust community health worker program in the United States. Brazil has one. And that together, has been, this Programa de Saúde da Família has been targeting, the communities or focused on communities that are most vulnerable and most marginalized. So another issue to address equity. The conditional cash transfers, this Bolsa Familia, that's been used in Mexico. Brazil is the largest country to employ a conditional cash transfer system as, for poverty reduction, health promotion. Conditional cash transfers are given for immunizations, given for school attendance, for well baby checkups, for prenatal care. Vertical programs such as mass vaccination. Brazil traditionally has done mass vaccination for MMR, for yellow fever. That ability to mobilize public health at a national level is built on a strong community infrastructure, public health and universal healthcare infrastructure. Informatics. Brazil has perhaps not the best, but has an advanced health informatic infrastructure. The ability to have one identifier that spans many different sectors, not only health and public health, but also social services, streamlines the ability to get data and to make evidence-based decision-making based on data. I was surprised when I was a co-chair of the Reopen Connecticut advisory group. When I got kind of flipped out when I heard that, that Connecticut changed its surveillance system from a DOS-based system to a Windows-based system in 2008. Brazil had done that in 1998. And I think, the other part, the last part is really the importance of good governance. And there's certainly caveats. And the recent administration by Bolsonaro in detonating, much of the gains that have been made and much of the capacity infrastructure and personnel, human resources that were really accrued over the last 20 years, 30 years of investment is a cautionary tale. But on many parts, Brazil has good governance with respect to public health. And I think that's, these are all important for when we think about the United States. We know about the health equities that occur over short distances with our own cities. I live in a city of New Haven, which is, inequitable. If I go 4 blocks from where I live, health outcomes, are significantly poorer than my neighborhood. And we'll see how that plays. We'll see how that plays out for in COVID. We know that this is an underlying driver of disproportionate health outcomes, both in the United States as globally and in the urban slums. And certainly this has been the experience of my colleagues and my team members in Brazil of the last 8 to 10 months. So what are the challenges? So as I mentioned, when we look at these pictures of Rio de Janeiro, this is the community of Rocinha, or this is Kibera in Nairobi, we're first struck at the scale of the work that we're going to have to do to address the 2 billion slum dwellers and people living in the most marginalized urban communities is massive. We also know there's quite a bit of heterogeneity within communities, between cities. The capacity, I think one of the major issues is that we haven't had the capacity to really to gain the evidence, really rigorous scientific evidence to identify effective generalizable interventions for these things. And this is really the major gap that we're facing. And then again, finally, the infectious diseases are the low-hanging fruit. The major issues that we're going to be dealing with will be the violence, mental health, diabetes, hypertension, and the aging populations. That's going to be happening in these communities in the next 20 to 30 years. And so I want to end up just by going through this. This was also presented, an American version of this was presented in an earlier talk about this issue of equality, equity, and liberty. And really what we need to do to not only to provide these boxes that, but also to remove the barriers. And the Brazilian take is this issue of liberty in terms of removing these boxes. So I'm going to stop here and just thank really, I think the heroes of this story are really the communities that we work with in Brazil and the team members, who come from those communities, both as researchers, students, as well as actors and players in setting these, in laying out these models and paradigms. So with that, thank you very much again. It's been a true pleasure to speak in this lecture series.
Thank you very much, Albert. It was really informative and really inspiring. We are taking questions using the Q&A tool on Zoom. And as those fill up, I actually have a couple of questions I was hoping to ask as we get additional ones from our audience. You talked about the juxtaposition of urban poor and urban wealthy. The physical proximity is stunning, as you showed us with the high-rise picture in the tennis courts and the favela next to it. Why do you think Aedes aegypti respect that distance, resulting in a really marked gradient of microcephaly and antibody positivity? I get it that those rich communities are more connected to Orlando, but they're sitting right next to the poor community. How do you disentangle that?
Yeah, so that's the importance of this, both the biology and the social determinants. And I think the major theme that at least comes out in a lot of the work that we've been doing and others in Brazil and many places is really the two together. The biology. Aedes is a human adapted mosquito. Its home range, it can go over many meters, tens of meters, dozens of meters, but it will sit where it can get best, its habitat, food and so forth. And so actually there's a distribution around that. And even though there are externalities, we had people with Zika, we certainly have people in dengue, and chikungunya, across classes, but the largest burden is still in the poor. And that's really the fundamentals of the social determinants of health. You can see many of the people living next to there in houses, they're in apartment buildings. Some of them have screened windows. They have access to repellents, to air conditioning, which communities right next to that. And we've seen this happen in the United States. You look at Laredo on one side, in Nuevo Laredo. You have more Aedes aegypti in Laredo on the Texas side, but in the Mexican side, even though there's better vector control, there's more dengue because of these underlying social determinants. So solutions are going to need to really combine the biology and the social determinants, especially if they're vertical ones.
Super, super. So we have a question in from Sharon Round. How does Brazil implement effective community participation in the decision-making processes about health? How do they ensure that that happens?
So that's the importance of structure. There is a legal structural framework in the Constitution that guarantees that whether it's health, education, any social services, any social rights, that that half the decision-making body is from the community. When we were implementing the sanitation projects, these vertical sanitation projects in the peri-urban slums, there were members. Half the members were actually people from our collaborators, our teams, who were community leaders, religious leaders, were on that. And that's so one. One, there's a structural framework that many countries don't have, in many lower middle income countries, but many developed countries don't have, for community participation. Not only community participation, but ensures community that these interventions are community driven. The second is really the issue of empowerment. And I think some of you may be familiar with the treatises or the works of Paulo Freire. the pedagogy of oppressed. Much of the Constitution, much of the people who formed the Constitution and who, whether they're working on adult literacy, whether they're working on public health, immunizations, came out of that ideology. And so I would credit those two issues.
Super. Sharon has a follow-up question. At least in my experience, it's highly variable whether community health workers are actually part of the formal sector or if it's a more informal sector. Are the community health workers that you're interacting with in the urban slums, are they part of the formal sector? Are they getting paid for their activities?
Right. So
and how does that influence the sort of their commitment level?
So Jake, that's a good question. And obviously you see a variation or heterogeneity throughout different countries about whether, they're formal or informal. They're part of the formal economy or informal economy. And there are many types of community health workers. I should have prefaced that the community healthcare system that I was talking about is a formal system. It's an article in the Constitution. It's a program, it's an act of Congress to make what they call Programa Saúde de Família, the family health program. And it's funded, has a budget, an allocated budget, and it has a mandate. It has a mandate to which populations, very clear metrics of which populations need to be served, in prioritized in that process. And these community health workers, they're giving immunizations, they're doing, measuring BMIs, they're measuring blood pressures, they're helping with a doctor, provide care for, health education on diabetes, on nutrition, and so forth.
I hear there's some folks that are moving to Washington soon that might want to be reading that Constitution and maybe reading a little bit about that health program. It really sounds phenomenal.
It's a torture to read. Again, that Constitution's 89 pages, and there's a good side and a bad side, but it does do what our Constitution doesn't, and that is guarantee social rights. And if you're going to build a robust public health program, you need to guarantee the social rights, and you need to, address those issues of social determinants that we do so poorly.
Let me pivot back to a bit of biology that surprised me in your talk, which was the leptospirosis outcomes by gender. Really surprised me. What do you think is going on there? And I wasn't fast enough to interpret the direction. Was it males more susceptible or less susceptible?
Males were more susceptible.
Why do you think that?
So there are two reasons. One is that there are gender-specific activities in the peri-urban. The transmission, unlike leptospirosis here in the United States, we hardly see a case. I never saw a case of leptospirosis before I went to Brazil, but they're usually worker associated, and many of those there's a gender bias in those workers. In Brazil, the transmission is peri-domestic. So there are things like cleaning out the sewer. There are things that that are gender associated. But the other is this issue, and this is the importance of social gradient, is that there are psychosocial factors in that gradient. And if we understand what those psychosocial factors are, we will have much more effective and much more targeted interventions. And this is the issue around risk. Walking into an open sewer, right? Or interacting with being exposed to a contaminated environment. And we see that same gradient play out, whether it's leptospirosis, whether it's toxoplasmosis. We see that happening when we're thinking about violence, substance abuse, all these very fine grained, very granular social grades, small gradations or small differences in the social gradient make large differences.
No, fantastic. Do we have any other questions for Dr. Ko here? I'm looking on the Q&A. I don't see anything on the Q&A. And at the moment, nothing from the chat. Folks, this is your chance. After 5 o'clock, he charges. No, with that, I think, Albert, those are the questions. It was an absolutely fabulous lecture. I really, really appreciate you taking the time to educate us and help us on our journey understanding how social determinants and poverty and SES all influence health outcomes. It has really been a fantastic talk and very inspirational. I really appreciate it.
All right. Thank you very much. It was really a pleasure. We appreciate the invitation.
Terrific. Take care, Albert. We'll see you
All
soon.
right, take care. Goodbye.